So we can start. We can start with Dr. Meghna Kandi. She's going to speak on retinal detachment. Please. The slides have not changed audio vision.
Meghna. Can I start, ma'am? Good morning, one and all. Today I am going to present case presentation on rhegmatogenous retinal detachment. A 50 years old male presented with sudden painless loss of vision in right eye since 2 months, which is associated with floaters and photopsia in right eye. There are floaters in left eye since 6 months. There is no history of trauma. There is no history of usage of any drugs. In past history, patient has history of hypertension and diabetic since 2 years and he is on medications. He is taking mixed diet, but there are no addictions. Family history is unremarkable for similar complaints. On general evaluation, his blood pressure is slightly raised. Rest all evaluation is within normal limit. On ophthalmic evaluation, his right eye vision is PL accurate with PR inaccurate. And in left eye, vision, best corrected visual acuity with plus 0.5 spherical is 6/6. And IOP with rebound tonometry is 10 and 18 millimeters of mercury. On slit lamp evaluation, rest anterior segment evaluation is within normal limit apart from RAPD in right eye. On fundus evaluation, both eyes, media is clear with normal size of the disc, normal shape of the disc with cup disc ratio of 0.3:1. And there is temporal quadrant of right eye, rhegmatogenous retinal detachment with lattices and horseshoe-shaped tears are present. And in left eye, there are multiple lattices with hole in lattices, indicating myopic lattice degeneration. These are the similar fundus images showing multiple pigmented lattices with horseshoe-shaped tears in right eye. And they are initially when we examined his left eye, posterior pole appeared absolutely normal. But when we checked the periphery, there are multiple pigmented lattices with holes in the lattice, indicating myopic lattice degeneration. He was routinely investigated for all blood investigations and he was sent for medicine fitness in view of diabetic and hypertension. And he was planned for right eye under local anesthesia, right eye vitrectomy with endo laser and silicone oil, and left eye under topical anesthesia. He was planned for laser for sealing of the lattices. And post-operative day 1, his retina appears attached with lasered HST and lattice with silicone oil. And in left eye, there are lasered lattices with double frequency and diag laser. In post-operative 1 week, best corrected visual acuity improved from PL positive with PR inaccurate to counting fingers half meter, and there are silicone oil reflex seen with attached retina. And post-operative picture, after removal of silicone oil 4 months, his best corrected visual acuity is improving only to 2 meters. But the retina is attached. Then when we evaluated, he has cataract with NS3 grade with PSC, posterior subcapsular cataract. And in right eye, there is hazy view. We can see the attached retina with laser lattices. Best corrected visual acuity in left eye is 6/6 with plus 0.5 diopter sphere, and he has NS1 cataract with PSC. This is the left eye laser lattice picture. When coming to review of literature, there is like if the retinal detachment is involving multiple planes, then pars plana vitrectomy has more anatomical success when compared to scleral buckling. And in patients who developed cataract after vitrectomy, there is increased chances of nuclear drop events occurring. So we prefer minimal incision cataract surgery when compared to phacoemulsification. So there should be vigilant ocular evaluation in patients having risk for retinal pathologies, and if there is retinal detachment in one eye, then thorough evaluation of periphery of other eye should be done, and patient should be counseled for regular follow-up, and retinal pathologies patient should be explained about the prognosis and post-operative positioning, and challenges should be during cataract surgery in post-vitrectomized eyes should be kept in mind. These are my references. Thank you.
I think it's a very good presentation and lots of learning in this case. Dr. Meghana, you said the PR was inaccurate in this patient in the beginning.
Yes, ma'am.
So what are the, can you just explain why the PR was inaccurate? Projection of rays because
there is
PVR and subretinal folds you didn't show because it shows that it is probably a very old retinal detachment.
Yes,
so what were the positive points in your case for projection of rays being inaccurate in the beginning?
Because there are more quadrants of retina being involved. In those quadrants, there is inaccurate PR, ma'am. Projection of rays.
No, but a fresh retinal detachment will not have inaccurate PR. This we need to learn. It will only be an old retinal detachment which will give you a projection of rays which are inaccurate.
This case is subacute presentation, ma'am. It is not acute, it is not chronic also, ma'am. When he presented, it is like 2 months old.
So that could be the reason of not improving vision after the cataract surgery as well after that. All right. Any further points, Dr. Ankur, Dr. Shishan?
So usually in a case of detachment, the PR should be accurate. I mean, it's only like if it's a very old detachment or there's a giant retinal tear, the retinal flap is not there. So sometimes there might be an inaccurate PR, and after surgery it returns back. So this case would not explain an inaccurate PR actually, as Madam said. So this needs to be explained further. And so what was the surgery exactly done in this case?
In him, we have done right eye vitrectomy with endo laser of the sealing of these breaks, and we have put silicone oil, sir.
Yeah. And silicone oil was removed later on?
Yes, sir. After 4 months, silicone oil was removed, sir.
And the cataract surgery was done?
No, sir. We are following him up for doing cataract surgery, sir.
Right. So
we have planned him this
month. So many
month.
times when cataract is there, so maybe the two can be combined at some point.
Initially, he don't have cataract, sir.
Correct. So when oil is removed, so maybe cataract can be done as well if it is significant.
So we'll go on to our next speaker.
Thank you.
Since Dr. Gautam, Dr. Kalapriya, Dr. Haleen Kaur are not there, so we go on to, sir, please call.
So we have Dr. Tanu Bhanot now for a rare case of hemorrhagic orbital proptosis post PPV leading to Glanzmann's thrombasthenia in a child with Sticklers.
Good morning, everyone. I'm going to present a rare case of hemorrhagic orbital proptosis post-PPV leading to incidental diagnosis of Glanzmann thrombasthenia in a child with Stickler syndrome. Complications of scleral buckle with pars plana vitrectomy include scleral perforation, subretinal hemorrhage, choroidal hemorrhage, retinal tears, and infections in the orbit. However, hemorrhagic orbital proptosis has not been reported in literature. This presentation aims to report a rare case of orbital proptosis and intraocular hemorrhage after scleral buckling and PPV for a regmatogenous retinal detachment in a case of Stickler syndrome. Investigations as to cause of bleeding showed a rare case of bleeding in our case. 11-year-old boy presented with sudden diminution of vision in the right eye since 2 months. He gave a history of recurrent epistaxis since 1 year of age, easy fatigability, joint pain since childhood, History of hospital admission previous month, post-episode of epistaxis, and history of blood transfusions in view of decreased hemoglobin levels. No history of similar complaints in the family. Patient was born to a second-degree consanguineous marriage. On ocular examination, best corrected visual acuity in the right eye was CF 1 meter, and in the left eye was CF 3 meters. Anterior segment was within normal limits in both the eyes. Posterior segment showed right eye subtotal retinal detachment extending from 2 o'clock to 10 o'clock meridian with macular involvement, and the left eye showed myopic fundus with peripapillary atrophy, annular crescent, highly tessellated background, and RPA atrophy. Diagnosis of right eye rhegmatogenous retinal detachment in case of Stickler syndrome was made. Diagnosis of Stickler syndrome is done by genetic analysis, which was not possible in our case as the patient was not affordable. Patient was planned for scleral buckling with pars plana vitrectomy, fluid air exchange, endolaser and silicone oil injection under GA. And a patient was granted pediatric and ENT reference, and he was given fitness. Hematological investigations here showed normal platelet count, normal hemoglobin, and APTT was within normal limits. On post-op day 1, he presented with conjunctival chemosis, subconjunctival hemorrhage, protrusion of the eyeball, which could be due to retrobulbar hemorrhage. Fundus examination showed no view of retina with vitreous hemorrhage, and vision was PL positive, PR accurate, and these were the pictures. This was the ultrasound which was done. On further workup, hematological workup in specialized centers showed deficiency of GP2B3A receptor, and diagnosis of Glanzmann thrombasthenia was made. Glanzmann thrombasthenia as a cause of ocular bleeding is not yet reported in literature. Patient was given platelet transfusions. Retrobulbar and vitreous hemorrhage subsided with platelet infusions, but retina remained redetached due to proliferative vitreoretinopathy. As it is autosomal recessive disease, all siblings were tested, and his younger sister, with no symptoms, also had the similar Glanzmann thrombasthenia diagnosis. Then normal platelet count, size, granularity on light microscopy will be present in such patients, but these cases will need more sophisticated tests. Any vitreous hemorrhage, orbital hemorrhage, or even eye-related complications associated with Glanzmann thrombasthenia are not yet reported in literature. To our surprise, literature search did not reveal any such results showing occurrence of Glanzmann thrombasthenia associated with Stickler syndrome, making this the first of a kind and rare one to witness. Epistaxis was the only common complaint that the patient was complaining, and it was not raising any suspicion of abnormal platelets preoperatively. Hence, post-surgery, bleeding complications led to further investigation in Glanzmann thrombasthenia in this case. Had it been a major surgery, where huge blood loss would have led to threat to patient's life. Preoperative assessment should pay attention to any history of repeated epistaxis or other bleeding episodes and should be investigated more robustly. Rare causes, as in our case, leads to compromise in surgical and functional results. Post-surgery. This was the 1-month follow-up of the patient, where the vision in the right eye was hand movements close to face, PL positive, PR accurate. After taking opinion from corneal specialist, he had exposure keratitis. That's why he was referred to corneal specialist. And his retina remained redetached. Patient's parents were advised for right eye revitrectomy for retinal detachment. However, they did not follow up. 1-year follow-up showed the right eye vision, PL positive, PR inaccurate. Patient is planned for right eye lensectomy with the silicone oil removal. Thank you. These are my references.
Thank you, Dr. Tanu. I think it's a very rare. Could you just mention how did you manage the retrobulbar hemorrhage in this case?
Ma'am, he was given repeated transfusions and platelet FFPs. Then he was controlled.
How many for how long did you give these?
It was repeatedly given.
Repeated means?
Ma'am, for 3 or 4 days we had to give transfusions.
3-4 days, because once you give the platelets will have some time period, no? So every day you need, I thought so.
Ma'am, yes, it was needed for this case.
So there are other causes of also post-PPV proptosis, simpler causes also, but this case of course was a retrobulbar hemorrhage, as you said. Yes, any further question on this?
How much days did it took the RBS to subside down in your patient? Like the first picture that was taken was when these things happened.
So 4 days.
4 days.
But he came after 1 week again. He was normal, sir. Even the fundus we could visualize that time. But
and what about the vitreous hemorrhage?
Sir, it remained. Sir, it was not corrected. Since he was planned for again PPV in the right eye.
So it's a nice case, doctor. Are you planning to report this case? It's worth reporting actually.
So yes, we'll go ahead, sir.
Sticklers is not very common in our circumstances, but we do see cases, and the prognosis is not very good in sticklers. So that is the point to remember.
Yes, sir.
That's it.
Thank you, sir.
Can we have the next speaker, Nivedha? Uncommon encounter retinal vein occlusion.
Good morning. This is a rare case of retinal vein occlusion in a 16-year-old. As we all know, central retinal vein occlusion is commonly associated with the elderly. Occurrence in young patients presents a unique set of challenges and diagnostic considerations. So we had a 16-year-old girl who came to our OPD with chief complaints of left eye sudden painless loss of vision since 3 days, was not associated with any other symptoms. There's no history of trauma. There was no previous systemic or ocular medical history. There's no significant family history. On ocular examination, right eye showed visual acuity of 6/6, anterior segment and fundus was normal, IOP was within normal limits. Left eye visual acuity was 2/60 with no improvement with pinhole. Anterior segment examination was normal, there was no RAPD. Intraocular pressure was within normal limits. Left eye fundus showed blurred disc margin with hyperemia with dilated tortuous vessels and flame-shaped hemorrhages and cotton wool spots in all 4 quadrants. And a left eye OCT was done which showed cystoid spaces and increased accumulation of intraretinal fluid which was suggestive of macular edema. BP was within normal limits and general examination and systemic examination was normal. Further investigation was done. Complete blood count showed decreased hemoglobin and ESR and CRP was elevated and increased homocysteine level was noted and was referred to a physician, and the renal function test showed increased urea, creatinine. There was an electrolyte imbalance and albumin traces were found in the urine. Ultrasound kidney showed bilateral multiple cyst with hemolytic content. So we came to a diagnosis of left eye central retinal vein occlusion associated with autosomal dominant polycystic kidney disease. Ocular intervention that was done was 1 dose of intravitreal injection bevacizumab was given along with folic acid supplements and was immediately referred to a physician. And a physician had started on iron calcium supplements, hepatitis B injection was given and diet restrictions was advised. Patient underwent AV fistula and was advised renal transplantation. The patient was followed up 10 days after injection bevacizumab and left eye visual acuity showed 6/18 powers with no improvement with pinhole. The left eye fundus showed exudates in a macular star pattern suggestive of reduced macular edema, and OCT showed reduced macular edema. So the review of literature suggested that the prevalence of retinal vein occlusion increases with age, whereas the pathogenesis and risk factors in young patients are still very unclear. So for a few studies show that hypocoagulable state was responsible for the central retinal vein occlusion with these causes. And one study which was done in 2000 showed that increased plasma homocysteine level is increased in diabetic patients but are more related to reduced renal function. A study done in 2007 showed that the venous occlusion may be a part of generalized vasculopathy associated with autosomal dominant polycystic kidney disease. Another study showed that pathogenic mechanism for end-stage renal disease includes vascular endothelial dysfunction and arteriosclerosis contributes to the renal vein occlusion. And a study done by Rothman showed that the number of anti-VEGF injections was lower in young patients than in elderly patients. The patient was followed up 1 month later and the left eye best corrected visual acuity was 6/6 powers. So the take-home message is that unusual presentation of CRVO in young patients should always be investigated. This might always require a multidisciplinary approach, and the patient should undergo a genetic counseling and regular monitoring.
Thank you, Dr. Niveda. Can you just tell polycystic kidney, how is it related to homocystinuria? Decrease?
There's increased homocysteine level.
Oh, I'm sorry, yes. How does this correlate? Is there a correlation between the both? Because the patient had hypercoagulability state because of homocystinemia
yes,
increased. So is there any correlation between polycystic kidney and
the renal disorders are generally associated with increased homocysteine levels, ma'am, but here the patient was diagnosed with autosomal dominant polycystic kidney.
So both are independent of each other? She had no hypertension, as you said.
No, she had no hypertension.
So both are independent of each other.
But she did have.
All right, it's fine. It's okay. So
usually after ruling out diabetes and blood pressure, of course in elderly and in young patients could be so many other reasons, autoimmune as well. So one very common thing which used to be pretty common earlier, not now, was a variant of eels actually, papillophlebitis we used to call it. So a trial of oral steroids, if everything else is normal, that would actually at times just resolve the condition, and it finishes off the CRVO picture. It could be because of an eels-like picture so many times. It used to be quite common earlier on, but now because somehow the eels has gone down, so even this picture is not very common now, but this is one possibility to be kept in mind.
what was the final vision gain?
6 passed now.
So just as we used to call it non-ischemic type of a CRVO, but of course the homocysteine is high, polycystic kidneys, so she had so many other problems associated, which was incidentally.
Can we have the next speaker, Dr. Ajay, for Leber multiple miliary aneurysm?
So good morning. I'd like to present an interesting case on Leber's multiple miliary aneurysm. The name might sound complicated, but it's actually literature states that it is a milder version of the well-known Coats disease. As Dr. Priyanka presented earlier, a similar case, she did a very excellent job where she illustrated many pictures on Coats disease, making my job a bit easier. So this is a fundus picture of a patient with Leber's multiple miliary aneurysm. It is a localized, less severe form of Coats found in adults, unlike the Coats disease, which is found in young children. And it has a male preponderance and presence with decreased vision. And clinically, it presents with aneurysms of the temporal and peripheral retina, leading to chronic leakage with intraretinal exudates at the macula. So my patient was a 30-year-old gentleman who was a farmer by occupation who presented with right eye defective vision for the past 3 months. There was no significant negative history in his past ocular and past history were unremarkable. His general and systemic examination also was unremarkable as expected in a 30-year-old male. His left eye was totally normal, including his fundus and intraocular pleasures. His right eye had a distance vision of 560, which did not improve in pinhole. And his IOP was 12 millimeters of mercury, and his anterior segment was normal. This was his fundus picture. He had normal discs and vessels. His temporal retina showed multiple microaneurysms, and he had big subretinal exudate plaque sitting at the macula, which was causing the defective vision. His foveal reflex was also absent, indicative of macular edema, but his periphery was normal. So we went ahead and investigated with the macular OCT, which clearly shows a subretinal exudate right at the macula with cystoid macular edema. We went ahead and did baseline blood investigations with complete hemogram, including ESR, CRP, and his sugars. Everything turned out to be normal. We also planned for an FFA, but patient did not consent because of on monetary basis. So for the macular edema, we decided to go ahead with an intravitreal bevacizumab and was reviewed on a monthly basis. So 1 month post Avastin, this is macular OCT picture. We can see that the edema is completely subsided, and the exudate has also been a bit organized than what it was before. A similar case was presented in the University of Korea, where a 30-year-old female with no comorbidities presented with similar complaints and was given 2 doses of bevacizumab, and her vision improved from 612 to 6.6. So, a similar cases in young males with vision loss with intraretinal exudates and saccular aneurysm always suspect Leber's rather than Coates disease. Coates disease, the patient will present with more serious exudative detachments of sorts, but this is a milder version of Coates disease, which can be proven on an OCT. And FFA, if done, will show multiple miliary aneurysms with extravasations and capillary non-perfusion areas. You can treat the capillary non-perfusion areas with laser photocoagulation, but the mainstay of treatment would be an intravitreal anti-VEGF or IVTA. So the patient was followed up for a period of 1 month, where vision was improved, and this was his fundus picture at the end of 1 month. So his vision improved from 560 to 618, and there was reduction of subretinal exudates and microaneurysms, and the OCT showed resolution of macular edema. So if you always find a similar case with findings at the posterior pole, it is mandatory to do an indirect ophthalmoscopy to examine a periphery, as you might be missing a peripheral lesion, considering the age of the patient, which is very important. Thank you.
Thank you. I think it was a very good pictures which you showed us. Just one question. Like you gave one anti-VEGF and
Yes,
there was a dramatic improvement. So could you see the aneurysms around? So like you have to
Aneurysms were reduced in number and in size, but not completely resolved, unlike the edema, which was completely resolved with one intravitreal bevacizumab.
So the
A PVD injection is being done. Now we are doing a brilliant blue assisted ILM peeling. A small amount of PFCL is given, and finally the peeled ILM is being put into the optic disc pit, basically providing a scaffold effect. And finally, C3F8 is given, fax followed by C3F8. The post-operative best curve visual acuity in the right eye was 6/24, and after 1 month, the OCT showed a decrease in the macular thickness up to 480 micrometers, and after 2 months, we can see there is a reattachment between the retinal layers. This was a pre-operative fundus photograph, and this is the post-operative fundus photograph. So just coming to the clinical implications, a few points. Patients with optic disc pits are diagnosed incidentally and should be counseled on the risk for development of optic disc pit maculopathy. The most commonly used procedure for the treatment is PPV, especially in the recent years. Limited vitrectomy with intraretinal fenestration is a recently described technique that has promising results, but visual recovery is, however, slow and takes a long process, up to 6 to 12 months. Thank you.
I think it's a very well managed and very good pictures and videos which you have shown.
Thank you,
I think, as you said, PPV along with ILM peel and ILM over the pit.
Yes,
So these, and you put a PFCL to keep the ILM in place. I think it was a very right management.
We could not do much in earlier days, just that little barrage laser temporarily used to be done, but there were no results after this. But then past planar vitrectomy and the surgery with the gas and prone positioning, it gives result in cases, and maculopathy, it tends to resolve. A nice case.
Thank you.
So, next we have Shraddha Prabha, vitreous cyst, clinical rarity.
Very good morning to everyone present over here. I'm Dr. Shraddha from Odisha and would like to present a case of a vitreous cyst, a clinical rarity. So these cysts represent an extremely rare clinical entity which could be either detected incidentally or congenital or acquired. Theories suggest that they could be choriostoma of the primary hyaloid system. They can occur in normal eyes as well as in those with certain ocular pathologies. Patient report transient blurring of vision when the cyst floats in the area visual axis. But surprisingly, our subject did not complain of any such floaters or blurring of vision despite the cyst freely floating in the visual axis. So this was basically a 20-year-old female, a college student by profession from Jajpur district of Odisha, who turned up to our OPD for a routine checkup. There was no recent diminution of vision or any other ocular symptoms. She was detected incidentally with high myopia 10 years back when she was in standard 8 and is wearing glasses since then. And there is no history of floaters or any other ocular trauma. Family history was insignificant. Upon further questioning, there was history of goats as pets in the home. General examination and systemic examination was completely within normal limit. Coming to the ocular examination, she had a best corrected visual acuity of 612 parts in both eyes with the IOP of 14 millimeters of mercury in both eyes. Rest of the external examination was completely normal. Coming to the slit lamp biomicroscopy, the lid and adnexa and the rest of the anterior segment was normal. Upon dilated examination, media was clear in both the eyes with a cup disc ratio of 0.3:1 with a healthy neuroretinal rim with the presence of foveal reflex, and fundus had no other degeneration. But on the left eye, there was a freely floating cyst noted in the anterior vitreous pocket, which was along with the movement of the eyes. It was spherical in shape, smooth surfaced, about 2 × 2 mm in dimension, light brown in color, non-pigmented. And surprisingly, the patient is not complaining of any visual symptoms. So we did further imaging. These are the various pictures in the anterior segment imaging, and the fundus photograph was again completely normal. Upon the B-scan imaging, we found a 2 × 2 mm cystic formation in the anterior vitreous pocket with hyperechoic walls, which was freely floating and did not have any attachment to any other ocular structures. Upon complete blood count, it was completely normal with a hemoglobin of 10 gram percentage. Blood serology test, that is the IgG and IgM, were negative for Toxoplasma gondii. ESR was significantly raised. Stool routine microscopy was negative for protozoan ovae. VDRL was negative. NCCT brain, chest X-ray PA view, and CT scan abdomen and pelvis was completely normal. So as the patient was completely asymptomatic, she was followed up for 6 months with regular assessment of visual acuity and fundus examination, and also stool routine microscopy. But yes, symptomatic cysts are managed by laser cystotomy by argon or NDR laser, pars plana vitrectomy with cyst excision. So to conclude, we presume this to be a case of congenital vitreous cyst associated with high myopia, which is completely asymptomatic without any ocular attachment. They can be congenital or acquired. If acquired, they can be reported secondary to ocular trauma, intermittent uveitis, toxoplasmosis, and echinococcus infection. They could also be associated with retinitis pigmentosa, choroidal atrophy, retinoschisis, high myopia with uveal coloboma, and retinal detachment surgeries. However, there was no such association, and surprisingly, congenital cysts are also considered to be remnants or choriostomas of the primary hyaloid system, and they could be in conjunction with a Mittendorf dot or a Burgmeister's papillae, but there was no such association in our case. Thank you.
I think it's a very good presentation because of simple observation, sometimes when you see something, you are itching to remove it. So we learn that in case of such, we're treating the patient's symptoms and not the signs. So patient has no symptoms, so nothing to be done. Thank you.
It's a good case, thanks.
Can we have the next presenter? Dr. Parmeet Singh, submacular neurocysticercosis, cyst with macular hole.
Good morning. Good morning, everyone. I'm presenting a case of submacular cysticercosis. 15-year-old male who was a resident of Mohali, Punjab, presented to the OPD department of GMCH with a chief complaint of deterioration of vision in left eye since 1 week. The patient was well 1 week back when he spontaneously started having painful diminution of vision in his left eye, which was sudden in onset, gradually progressive and associated with moderate pain and redness. There was no history of photophobia, colored halos, flashes, trauma, any contact lens use, eye surgery, or any remarkable systemic complaints. There was no history of travel elsewhere. Family history was not significant. Patient was a non-smoker, non-drinker, and a non-vegetarian. General physical examination was unremarkable. On slit lamp examination, right eye was apparently well, while the left eye showed a vision of finger counting 2 meters. And in the anterior segment, there was circumciliary congestion present. The cornea was clear with no cratic precipitates. There was an AC reaction of 3+ and flare 3+ according to the Sun classification. Angles were open and there were no granulomas. Iris, pupil, and lens were within normal limits. The posterior segment examination of the right eye was within normal limits, but the left eye showed a well-defined translucent subretinal cystic lesion, which was about 2.5 diameter in size, containing an intracystic dense white lesion. On the OCT, the OCT revealed I'm not able to play this. Cystic lesion in the subretinal area with the elevated neurosensory retina with full thickness macular hole and an hyperreflective area inside the cyst with the back shadow. So we have a 15-year-old Indian male who had a sudden paleness decrease in vision. His left eye vision was finger counting 2 meters, and posterior segment revealed a submacular cystic lesion with macular hole. Final diagnosis straightaway was made of intraocular cysticercosis with macular hole. Patient was asked about if he has eaten any pork, and he revealed that yes, he was a pork eater. MRI of the brain, orbit, and spine was ordered. MRI showed multiple enhancing lesions in the brain parenchyma, similarly in the spine. This is a video. Patient was managed by doing PPV. This is vitrectomy being done. And then retinal break was made with diathermy. The cyst was assisted out with the help of silicone tape cannula and the endoforceps, which was then sent for histopathological examination. And which revealed a cyst showing a parasite having a thin wall composed of outer cuticle layer, middle cellular layer, and the innermost reticular layer, along with the presence of scolex and the hooklets. Patient was put on tablet albendazole under the cover of steroid and Aptoin. And from our side, he was advised strict proning for 3 days. He was given eye drop betamethasone plus moxifloxacin 2 hourly, atropine 3 times per day, and carboxymethyl cellulase 6 times per day. Post-op, 1 month later, his vision was finger counting 4 meters. Anterior segment was within the normal limits, and the posterior segment showed a discolored central retina with a superficial hemorrhage and a chorioretinal scar temporally at the region of diathermy. This is the OCT finding showing macular edema. Macular hole seems closed and an intact RP. Thank you.
I think it's a very wonderfully managed case. The whole cyst without rupture was brought out. Normally, some surgeons will just eat away the cyst so that by chance it ruptures, it can cause a lot of problems also. So I think that's a very good case. You didn't mention about the macular hole. Was the ILM peeled? And
Yes, sorry, yes.
you didn't mention the management of the macular hole.
Yes, ILM peeling was done, and then the ILM was tucked inside the macula.
All right.
Yes.
So that was done. And if it's a case of neurocystic sarcosis, usually the ophthalmologist does not start albendazole because there could be a problem in the brain. So it's usually the neurologist.
Yes, it wasn't started. It was started by the
because first steroid cover has to be given
Yes, ma'am.
for our learning itself. I think, thank you.
So it's a very nice case. Just one or two things that we need to be very sure about in any kind of macular surgeries is that how tempting it is that you see that cyst with a macular hole, never remove any cyst or subretinal fluid through the macular hole. So this case, because that will lead to damage to the fovea permanently. Second, this case was managed very well. You took out the cyst from a just at the junction of the normal and detached retina. The third thing is that after ILM peeling, you could have even gone away with without doing laser. I think you've done laser in this patient.
Yes, we did.
So that's do a good ILM peeling. There's already a certain inflammation over there. Put in gas in this patient, and this retina will attach. So
Yes, the gas was also put
yeah.
in the
So,
last
and at the same time, whenever you are taking out a cyst all the way up, sometimes there are chances that while holding the cyst, you might rupture it, and then you are in a bigger soup. So now the machines that we have eat away the cyst inside the vitreous cavity. Nothing is going to happen. So, thank you.
Thank you.
Can we have the next speaker, Dr. Sonali Pradhan, wound infection, post-cataract surgery?
Shall I start? Good afternoon, everyone. Today I am going to present a case of wound infection post-cataract surgery. Now, infections following cataract surgery are relatively uncommon, but it can occur and can present as endophthalmitis or very rarely as wound infection. Our case was a 67-year-old male with sudden onset of painful red eye, gross diminution of vision in right eye since 3 days. He had an uneventful phacoemulsification surgery done in right eye 1 month back, and on first week follow-up, it was normal. He did not give a history of recent trauma, fever. He was not diabetic, not hypertensive. And these were his findings. His vision had decreased to PL positive, PR inaccurate, and the IOP was raised. As we can see in the figure, there was lid edema, superior conjunctival congestion. There were corneal infiltrates of 3 mm into 3 mm size at the site of phaco wound and DM folds. Anterior chamber showed grade 3 reaction with hypopion. PCIL was seen in the back. Anterior vitreous and fundus both were hazy, but the red glow was visible. We had two differentials. One is endophthalmitis, and the other one is corneal wound infection. We did a B scan of the right eye, and it was found to be anechoic. Ruled out posterior segment involvement. Corneal scrapings and AC tap were obtained and sent for culture, but no organism were isolated in the culture. And the blood investigations were normal. LPA was done in both the eyes, which was patent, and it ruled out nasolacrimal duct obstruction, which could have been a potential source of infection. Our provisional diagnosis was wound infection. AC tap followed by AC wash was done with voriconazole and vancomycin. Patient was started on topical antibiotics, topical antifungal. Since his IOP was raised, he was given IOP lowering agents. He was also given systemic antibiotics for a duration of 7 days. Now, when the patient came for the 7-day follow-up, the corneal infiltrates had significantly decreased, but there was surrounding corneal thinning. Anterior chamber showed a mild reaction, and there was no hypopion. His vision also improved to 660, and IOP was normal. We were able to see the antravitreous and the fundus. The disc and macula were within normal limits. Banu Kosar et al. Had reviewed 7 cases of corneal wound infection, and 6 out of 7 patients recovered on topical fortified antibiotics. KD et al. Investigated 5 cases of wound infection, and 4 patients completely improved on fortified topical antibiotics. Garg et al. reported 7 cases of fungal infection of the wound, and 5 cases progressed to endophthalmitis, and ultimately those cases became thicical. So even if we detect the case and treat it, we need to have a follow-up of such patients. So it is very important to do a proper post-operative evaluation of such patients. We need to find out the risk factors of wound infection, like the poor wound construction, wound leak, any ocular adnexal infection, poor control of systemic factors like blood glucose, and wound infection, if not timely managed, it can lead to endophthalmitis. These are my references. Thank you.
Thank you. I think this is a very important case to teach us that pre-operative evaluation is very important for the patient had an NLD block.
Yes, ma'am.
So if the patient has an NLD block, this has to be actually picked up pre-operatively and managed before the patient is taken up for cataract surgery.
Yes, ma'am.
So you were very lucky that the patient did not have endophthalmitis and just had a wound infection, which you could mention, which you could manage so well. So, and also other, what are the other risk factors for these type of wound infections? And usually even excessive cautery, though clear corneal incisions, no cautery is done, but sometimes if there's a bleeding, some cautery is again done. So this all needs a very per-operative and pre-operative management. And NLD has to be, and you did not mention that post-operative also, whether the NLD block was managed or not.
No, patient did not have a NLD block. It was always patent.
I thought you said...
No, ma'am. A patient came to us 1 month after the surgery with a wound infection.
So there was no NLD block?
No, ma'am. Pre-operatively, it was patent, and post-operatively, ma'am, it was patent.
Right. So I'm sorry, I thought it was blocked. So then what could be the cause in your case for wound infection?
Ma'am, we thought that it may be a improper wound construction maybe, which was not.
Improper wound construction would also heal?
Ma'am, it was actually a trainee's case. So at the time of, at first follow-up, it was not, nothing was present. Patient did not inform us, it came after 1 month when he had a loss of vision. And
okay.
He did not complain of any kind of...
It could be a post-operative hygiene problem by the
yes,
patient also. Okay, all right.
Microbiology was done? Any scrapings were taken?
Yes, scrapings were taken, but organisms were not isolated. Actually, the sample was inadequate. We were not able to take out the sample much.
Even KOH and other things?
KOH was done, everything was done, but it came out to be negative.
You were very lucky that you could get away with just wound infection, not having endophthalmitis. Second thing is that one thing which is not considered to be very important is that Vasavra et al. In their study showed that there is trypan blue ingress. So when you close the wound of any cataract surgery patient, it should be a watertight wound. Sometime when there is a hypotony, at the same time you have closed the wound at a lesser pressure and it's not a watertight. So they have shown there is ingress of the trypan blue dye, and this could be the route for endophthalmitis. So just not the pre-operative care with the help of pre-operative, intraoperative care that is important. Sometimes even the slightest thing of getting the watertight seal of the wound, at the same time closing at the right IOP is also important. Thank you.
Thank you, sir.
So we go on to our next speaker, Dr. Yukta Patel. Viral co-infection in an immunocompetent male, a diagnostic quest.
So, good afternoon everyone. Myself Dr. Yukta Patel, first year DNB resident at Choithram Netralaya, Indore. Today I am going to present a rare but an interesting case of a viral retinitis in an immunocompetent male. So, a 35-year-old healthy male presented to our OPD with a complaint of diminution of vision in his right eye since 3 days. He had a past history of fever with chill in his past week, which was treated locally. His best corrected visual acuity in the affected eye was 2/60. Intraocular pressures were within normal limit. Anterior segment findings were also within normal limit. So we did the posterior segment evaluation of the affected eye, which showed blurring of the disc margin. There were sheathing of the blood vessels seen. There were superficial and deep hemorrhages seen, and there were exudation seen at the posterior pole. There was also posterior hypopyon seen, which was due to the accumulation of the exudate. So we decided to do OCT of the affected eye, which showed hyperreflective cells. There was an elevated membrane over the retina. There was intraretinal fluid and edema. And there was inner layer hyperreflectivity, which suggests inner layer ischemia. So based on the clinical examination, we had following differentials in our mind. So we decided to do investigation for various bacterial and viral infections, which came out to be negative. HIV was negative, syphilis was also negative. CDR count were also within normal limits. So we decided to do AC tap for PCR titers, and to our surprise, it came out to be positive for both CMV and VZV infection. So based on the clinical examination and lab reports, we came to a provisional diagnosis of CMV and VZV retinitis in an immunocompetent male. So we started our patient on tablet valaganciclovir 900 milligram BD along with the oral steroid as an induction dose. 1 week later, patient came to our follow-up with the deterioration of the vision to hand movements, which was due to the immune-mediated reaction in the patient due to the immunocompetent status of the male. But we continued with our antiviral therapy and steroids. So we could see gradual clearing of the vitritis and improvement in the vision of the patient. We can see the diminution in the vitritis. But the patient at 1 month came with the complaint of constant flashes in front of eyes. So we examined the posterior segment and we could find exudate clogged in the posterior segment. We couldn't find any retinal breaks in the posterior segment. So we decided to take the patient for vitrectomy. And intra, we could find a horseshoe-shaped retinal detachment, which was intraoperatively lasered. So after vitrectomy was done, the media became clear, the vitritis settled, and hemorrhages and exudate were also cleared. But there was a macular scar at the site of the origin of the infection, which was responsible for the low vision of the patient. On doing OCT, we can see the outer retinal necrosis at the site of the infection, which was responsible for this low visual acuity of the patient. So this is the post-op image of the patient at 4 months. We continued our antiviral therapy for 3 more months and tapered down the steroids. And at 1 year follow-up, the patient ocular conditions were stable. Thank you.
I think it's a very, very good case presentation because they are really a diagnostic dilemma, and you were brave enough to do a AC tap and find out the diagnosis itself. And of course, yes, it's very important to start steroids as well after 1 week of cover of antivirals. That's a very important message as well. And if they do not clear, then vitrectomy, and then because the retina is weak, there could be a break, and that needs management itself. Though the patient did not gain good vision, but I think it was a very well managed case.
Thank you. Nicely managed. And so the first diagnosis differential on seeing the clinical picture would have been this. And yes, of course, it was confirmed with the AC tap and with the investigations. Thank you. So we have the last case now, Markandeya Singh on foveal aplasia.
Can I, Dr. Anurag, can I invite you on the desk, please?
Very good afternoon to all assembled here. I am Dr. Markandeya Singh. I will be presenting a case of foveal hypoplasia in a 14-year-old patient. Foveal hypoplasia is an ocular abnormality in which the foveal pit does not develop or does not develop completely. It is associated with poor visual acuity, and it may be associated with other conditions such as albinism, optic nerve hypoplasia, aniridia, and nystagmus. Case details: a 14-year-old female patient presented to our IOPD with complaints of severe diminution of vision in the left eye. Since birth, her delivery was normal. At 9 months of gestation, all the family members were in good health. Systemic examination showed no abnormalities, and there was no associated nystagmus, aniridia, iris transillumination, skin hypopigmentation, or cataract. Upon ocular examination, eyebrow, eyelid, eyeball, palpebral aperture, conjunctiva, and anterior chamber in both the eyes were within normal limit. Cornea in both eyes was clear, and extraocular movements was full in all gazes in both the eyes. Iris was within normal limits. The pupil in both the eyes were round, regular, and reactive to light. Intraocular pressure in the right eye was 16 millimeters of mercury, and that in the left eye was 18 millimeters of mercury. The visual acuity in the right eye was 6/9, while it was finger counting at half meter in the left eye, which did not improve with pinhole. Fundus in the right eye showed normal fundal glow. The media was clear. The foveal reflex was present, and optic disc was within normal limits with a cup disc ratio of 0.3. The peripheral fundus was within normal limits as well. In the left eye, the fundal glow was normal, the media was clear, the foveal reflex was absent, and the optic disc was vertically oval with a cup disc ratio of 0.4. The peripheral fundus was again within normal limits. Investigations, first of all, we did an optical coherence tomography, which in the right eye was within normal limits. However, in the left eye, the foveal pit was conspicuously absent, and there was persistence of the inner retinal layers through the expected area of the fovea. This is the OCT image of the left eye, which shows the absence of the foveal pit in the left eye. Then we did a digital fundus photography in which the right eye showed optic disc within normal limits, the foveal reflex was present, and the peripheral fundus was within normal limits. The left eye, there was a vertically oval optic disc with foveal reflex was absent, and the peripheral fundus was within normal limit. This is the DFP picture showing the foveal reflex present in the right eye, which is absent in the left eye, thus indicating this is a case of foveal aplasia. Treatment, the patient was explained regarding the poor prognosis of vision in the left eye and was prescribed spectacles after refraction and was advised for regular follow-ups. Discussion, foveal aplasia is an ocular abnormality in which the foveal pit does not develop or does not completely develop. Early descriptions of foveal hypoplasia in the early 1900s were in association with other diseases, particularly hereditary nystagmus, while assessing for retinal abnormalities with ophthalmoscopy. A cross-sectional study done by Novell et al. With 286 healthy children found that up to 3% of children had an anatomically underdeveloped foveal pit bilaterally on OCT. Prematurity is a significant risk factor due to associated abnormal developments of retinal vasculature and deficiency of macular pigmentation in these patients. Foveal hypoplasia is also associated with albinism, aniridia, optic nerve hypoplasia, among others. The mechanism behind foveal hypoplasia is still not certain. One theory states that in fetal development, the foveal avascular zone does not develop, and instead astrocytes induce retinal endothelial cell migration across the fovea, which inhibits the foveal pit to form. And Thomas M.G. et al. Developed an OCT-based grading system for foveal hypoplasia based on unique foveal specialization features visible on OCT, which include foveal depth, outer segment lengthening, and outer nuclear widening. Thank you.
So I think that was a good presentation. It is a rare case, and yes, it's nice to know these cases. Any comments from the? Thank you. All right. So there are no are there any questions from the audience to any of the speakers or to the panelists? So if there are none, so I thank all of you, to all my panelists, for a wonderful session we had. A lot of learning process amongst each other as well as speakers and yourself. So we end here. Thank you so much. Yeah, there's some questions, or there's some speakers who are recently joined us. Please come forwards. Yes, somebody is walking towards the stage. You have a question, or are you a speaker? You're a speaker? Please join us. So kindly speak your good name. Any other speakers who have joined us late?
Good morning, everyone. I'm going to present on complete and early vitrectomy for acute post-op endophthalmitis. So, endophthalmitis is an inflammation of internal layer of eye, which can be due to intraocular colonization of infectious agent and manifest as exudation in vitreous cavity. The commonest cause of endophthalmitis is breach in integrity of ocular coats. That may be due to intraocular surgery or penetrating trauma. Post-op endophthalmitis is one of the most dreaded complications of intraocular surgery. So, our case of 55-year-old female from Patna, Bihar, presented to our OPD with complaints of diminution of vision, pain, redness in right eye since 7 days. There was history of right eye phaco which was done elsewhere, and the history of raised RBS, which was not known during the cataract surgery. On ocular examination, her vision was hand movement close to face with PL positive and PR accurate. There was periocular swelling with tenderness and edema of upper and lower lid and matting of lashes. Her extraocular movement was free and full and painless in all directions, and her corneal finding shows corneal edema with DM folds. Her anterior chamber shows AC cells of +4 with fibrinous membrane over iris and IOL. Her posterior segment B scan finding shows multiple dot and clump with few membranous vitreous echoes with confluence of exudates, which are the findings suggestive of vitritis. Her RCS complex were thickened. On blood investigation, it shows raised WBC with HbA1c was also raised. So the final diagnosis of right eye acute post-op endophthalmitis was made. And she was immediately taken for right eye vitreous tap with intravitreal VCD, and she was managed to medically with injectable antibiotics, as well as fortified eye drops were started. So the plan of right eye vitrectomy with vitreous biopsy and intravitreal VCD and AC tap was done. On first day follow-up, it was shown that her visual acuity was improved from 5/60 to 6/36 with improved in media clarity, as well as on first week follow-up, the vision was improved till 6/9, and the AC reaction was also decreased with improvement in media clarity. So on discussion part, due to limitation of EVS study, that is core vitrectomy is done in only the patient presenting with PL, PR, which lead to poor visual recovery. So CEV was done to reduce the inflammatory debris load as well as large specimen for diagnostic evaluation. CEV is judged on the basis of fundal glow. So complete vitrectomy is useful as it decreases the inflammatory debris in vitreous cavity as well as reduces the incidence and severity of macular complication. Large specimen for diagnostic evaluation was also provided due to complete vitrectomy. And early vitrectomy is done due to immediate treatable pathologies as well as serves as a prophylactic measures. Thank you.
Thank you. I think it was a well-managed case. But what was the HbA1c pre-operatively?
Ma'am, she was not checked at that time. She was operated elsewhere. So she was not checked at that time.
So that is the main problem, because HbA1c 8.8 and means if the patient is operated with such high glucose levels in the blood, it would cause problems. So the learning is that we must see that the diabetes is well controlled, otherwise it becomes a highest risk factor for endophthalmitis. And since now 8.8 cannot be controlled very well, so early vitrectomy and then management of the diabetes is also very important.
Given intravitreal antibiotics as well?
Yes, sir.
Intravitreal antibiotics were given?
Yes, sir. Yes, sir.
After vitrectomy?
Before vitrectomy also, and after vitrectomy also.
It was a nice presentation, but as Sir mentioned, instead of saying VDA, say vancomycin, dexamethasone, because whenever at postgraduate level, when we are presenting ourselves, we should not avoid using short forms, because tend to miss. So you did use VDA like vancomycin. So try and bring out the full form rather than the short forms. Thank you.
So thank you all once again. So we come to the end of the session, and I hope we have a lot of learning. There's another hands up, so there's a comment.
Glucose level before taking up for cataract surgery.
All right, so the question is, what should be the blood glucose level before taking the patient for cataract surgery?
One, if the patient is a known diabetic, and second, if it's a newly diagnosed diabetic.
If it's a known diabetic and if it's a newly diagnosed diabetes. I would like to say in our institute, because the WHO says that levels should be less than 180 pp, postprandial 180, so we stick to that. Levels should be less than 180 before we take up the patient, any diabetic patient, for cataract surgery or any intraocular surgery. Even for intravitreal also, we do not take patients who are more than 180. We control the diabetes and then give. Other panelists can also give their views.
So the norm has been to do it in less than 200 milligrams. So that is what we stick to, and doing it at a higher blood sugar levels, you can do it and you can just be fine, but then it would not hold in the court of law. That is one important thing. So in case you land up in trouble, so that is going to be a problem.
I would like to clarify here. Earlier it was 200. We also followed till 200 till our anesthetist showed me the new rules which said 180. So they will not take up the patient if the patient is under GST if the levels are beyond 180.
But madam, we all have seen in patients who are known diabetic for 10, 15 years, it is so difficult to bring it down to 200.
No, we do admit the patients and they put on insulin or whatever we have to bring down before surgery to less than 180 before we take up. That is our rule at Lady Hardinge Medical College in Delhi.
So the thing is that it's very easy to bring down the blood glucose level preoperatively. It is difficult with the patient is hypertensive. Even if you have to plan a patient, you can bring down the level of blood glucose using insulin. What is more important apart from the level of blood glucose preoperatively is how do we manage this patient postoperatively. So during the postoperative period, always advise your patients to take the regular insulin to check blood glucose, because in the postoperative period, if they have a higher blood glucose, it is equally dangerous. So it's just not the preoperative blood sugar that is important, it is also the postoperative management. Thank you.
Yes, that's a very important point, because postoperative, if you have controlled it and then the patient has to be on regular insulin or whatever, it has to be at least for 1 or 2 months, he has to be totally controlled.
Thank you.
The point I think sir wanted to ask is, for example, we get a lot of cases of PDR with vitrecemiris and sugar going beyond 400. You need to do a preparatory cataract. So how to proceed about that? Would you wait till the sugar becomes less than 200, or you'll straight away go for surgery?
No, even for proliferative diabetic retinopathy, if you're going to operate for vitrectomy and you have to undergo a cataract surgery, so it is very important that the patient is, first of all, PAC fit. We all know, because we are going to give an intravitreal anti-VEGF before we take up the patient for vitreous hemorrhage. So he has to be PAC fit, and the PAC will not make it fit till the sugars are below 180. So whatever it is, we have to be patient. We have to see that their serum electrolytes, KFT, ECG, and sugars are below 180 before we take up for cataract surgery, because this patient is ultimately going to get an anti-VEGF and take up for vitrectomy. That's a very good discussion, and if there are no more questions, so we can end up here. Thank you very much.
One more presentation.
Who has just arrived, so we will take him up. So please introduce yourself.
Good afternoon all. I'm Dr. Darren, second year resident of ophthalmology from St. John's Medical College, Bangalore. So we know a macular hole is a full thickness defect of the neurosensory retina at the fovea, which occasionally can result after trauma. So incidence of traumatic macular hole is 1.4% in closed globe injuries and 0.15 in open globe injuries. So traumatic macular hole is a relatively uncommon manifestation of all types of ocular injuries. So we present a case of traumatic macular hole following severe blunt ocular trauma, its clinical features, treatment, and short-term outcomes. So we got a 23-year-old male patient who came to the emergency department of our institution with history of fall from his two-wheeler 6 hours prior to presentation. There is history of bleeding from his forehead. There is no history of loss of consciousness, vomiting, seizures, no evidence of any ENT bleed. He complains of diminution of vision of the left eye post the incident. No history of any bleeding from the eye, no diplopia, floaters, or flashes of light. So past history, the patient gives history of ocular trauma to the right eye 2 years back while operating a drilling machine. So suspected open globe injury, full details are not available to us. So he underwent surgery with no improvement to the visual acuity in the right eye. On examination, right eye, there is perception of light with projection of rays being accurate, and near vision less than N36, color perception is normal, color filters. Left eye, counting fingers at 3 meters, near vision less than N36. So On evaluation, anterior segment, right eye, lid and ocular adnexa were normal. Left eye showed an 8 cross 2 centimeters deep irregular laceration noted along the superior orbital ridge. So, and a dense subconjunctival hemorrhage with chemosis noted. So, in the right eye, cornea showed adherent leukoma in the visual axis with DM folds noted radiating from the adherent leukoma, and superficial corneal vascularizations were seen. On anterior chamber evaluation, it was shallow, and lens matter were noted in the anterior chamber at around 7 o'clock position through the iridodialysis defect. In the left eye, Vanner-X grade 3 with no cells of flare noted. In iris, normal color and pattern in the left eye. In the right, iridodialysis was noted from 7 to 10 o'clock position. Other details are not clearly made out due to the opacity. Pupil in the left eye is 3 mm brisk and ill-sustained, and the lens in the left eye was clear with partial Vossius ring noted. So on fundus evaluation, no view in the right eye. The left eye, the media was clear, the disc cup size shape margin was normal, with the cup disc ratio of 0.3%, with a healthy neuroretinal rim. Vessel arterial to venous ratio is 2:3, and background showed subretinal hemorrhage, suspecting choroidal ruptures superior to the optic disc and with peripapillary RPE hyperpigmentation. Macula showed a reddish circular macular defect noted with a absent foveal reflex. Vasquez-Allen test was done and it was found to be positive. Intraocular pressure was done and it was found to be 10 millimeters of mercury. Extraocular movements showed limitation in elevation, depression, and abduction. So investigations, we performed OCT macula, which is performed 24 hours after admission and noted to have a full thickness macular hole with basal diameter of 759 micrometers and minimum internal diameter of 403 micrometers with no evidence of any intraretinal cysts. B-scan was within normal limits. Fundus picture, right eye, there was no view. The left eye shows full thickness macular hole with a subretinal hemorrhage supranasal to the disc, which we are suspecting for choroidal rupture. So intervention, the patient was evaluated in emergency medicine by plastic surgery, neurosurgery, and ophthalmology. CT was done, which shows left orbital blowout fracture with fracture fragments noted to impinge upon the inferior rectus muscle with mild herniation of the intraorbital fat into the left maxillary sinus. Left optic nerve appears normal with mild surrounding fat stranding noted in the intraconal compartment, and left frontal pneumocephalus was noted. The patient was admitted under plastic surgery. Debridement with suturing of the lid laceration was done by plastic surgery. On fundus evaluation was found noted to have a full thickness macular hole with subretinal hemorrhage and choroidal rupture, as mentioned. The patient was started on intravenous methylprednisolone 1 gram once daily in view of the patient being one-eyed and suspecting traumatic optic neuropathy, and was continued for 5 days, following which he was started on oral steroids 40 milligram once daily and weekly tapered off. So, the patient was started on IV methylprednisolone and started on topical antibiotics. So discharge advice, the patient was discharged on oral steroids and was tapered off, and was also started on vitamin C. And patient was advised home Amsler charting for secondary CMBM. So outcome, so after initiating the treatment, IV methylprednisolone, spontaneous anatomic closure of the full thickness macular hole was observed after 72 hours. The visual acuity improved to counting fingers at 5 meters on day 1, 660 on day 2, and 636 parts on day 3. So, as per literature review done, retrospective case series study done by Chunling Lee et al. Showed that there was moderate rate of spontaneous closure with the mean time of closure being 9.5 weeks. In spontaneous closure of traumatic macular hole, an intact ellipsoid band was observed in the patients, and smaller basal diameter of 418. A small basal diameter was associated with spontaneous closure, but in our case, it was a bit larger. The study done by Manish Tandon et al. Was done to find a novel method for the management of traumatic macular hole by giving intravenous methylprednisolone, out of which 6 patients were given treatment within 44 hours. The patients who were given methylprednisolone, all patients had closure of a traumatic macular hole within 48 hours on an average, with improvement in visual acuity at the time of discharge and on later follow-up. So, on follow-up of our patient, the visual acuity in the affected eye was found to be 636, near vision to be N10 with normal color perception. On fundus evaluation, left eye showed resolved macular hole with the dull foveal reflex and with ILM folds. And resolving subretinal hemorrhage was seen. So OCT macula showed complete anatomical closure of the traumatic macular hole with foveal thinning. So clinical implication, since due to the low incidence of traumatic macular hole, there are no standard guidelines in the management of this condition, and spontaneous closure do occur, but most require surgical intervention for anatomical closure. So the hypothesis proposed for a study done by Manish Tandon et al. Is based on the fact that there occurs a breach in the blood retinal barrier, which is maximum in the first 72 hours, and IVMP will reduce the inflammation and help in the reparative process that helps in closure of the hole. So this case study demonstrates that high-dose IV methylprednisolone could hasten the closure of the macular hole with quick visual rehab for a potentially surgical condition, and could be considered as a novel management modality in the future if more cases are considered for treatment.
Thank you. I think this IVMP, even if, according to me, even if IVMP would not have been given, he would have closed. That is my view about it, because sometimes the patient is a diabetic and IVMP may not be given. So I don't know, is there a correlation between IVMP and traumatic hole closure? It is still under study, maybe,
Yes,
as you said. So that should be taken with a little, not taken as a take-home message. And what about the submacular hemorrhage, which you said because of the rupture of the corona?
Yes, ma'am.
How far was it from the fovea?
It was supranasal to the disc, not near to the fovea, ma'am.
Okay. All right. So because if there's a submacular hemorrhage little away from the macular hole, that would also need a management, early management, with at least with some intravitreal air and positioning of the patient. Any more comments, please?
So there has been a few case reports which have published role of steroids in macular hole closure. So first, we don't have any comparative randomized control trial comparing spontaneous macular hole closures and the patients who were given steroids. So making a statement, just the way you have chosen, that the role of methylprednisolone in a macular hole closure, it should be taken with a pinch of salt. Second is that traumatic macular holes are more prone to be persistent macular holes. So they getting closed with the help of methylprednisolone is still a doubt. Because when you say traumatic macular hole, in your case, the size was not bigger. But traumatic macular hole are usually up to the 1,000 micron size. In pediatric patients, they are very, they are very resilient to close without the surgery. So second thing is this. Third thing is those patients, in those patients who have received steroids and have closed the macular hole, they had a lot of intraretinal cystic spaces around the fovea that we tend to see. So the hypothesis that has been put in literature that it causes the decrease in the cystic fluid, and this might lead to the closure of these macular hole. But then we don't have any trials to say that. So as of now, for me, it is spontaneous closure, not because of the steroids.
Thank you.
Thank you. Thank you. So finally, if there are no more speakers, we can end up here. Do I see another hands up and somebody walking down? Thank you.
Thank you.
Thank you, please. We can have a picture. The official photographer is here. Otherwise, it can be from more. Yes, I can see another hands up from Dr. Astha. She will click the photograph for us, or? Thank you.